The webinar will be presented tonight by Dr. Yasmine Abdalla, consultant ophthalmologist. Dr. Abdalla is the Uveitis Third Lead at the University Hospitals of Derby and Burton NHS Foundation Trust and is a fellow of the Royal College of Ophthalmologists. This webinar is accredited for 1 CPD point for both optometrists and ophthalmologists. Thank you again to our sponsors, and I will hand over to Dr. Abdalla.
Thank you. Hi, everybody. So hope you're ready for our AMD whistle-stop tour. It's more of a roller coaster ride, so keep your seatbelt fastened, I think. So to begin with, okay, my slide, there we go. So to begin with, we'll talk about definition of AMD. I understand we've got a big audience from variable backgrounds, so let's start with the basics. So we all know that AMD is an acquired degeneration of the retina, specifically the macula, and it can cause central vision loss through either neovascular or non-neovascular pathologies. So non-neovascular like Drusen and retinal pigment epithelial anomalies, and obviously neovascular through neovascular membrane. The advanced disease may involve focal areas of RPE loss, subretinal or sub-RPE hemorrhage, serous fluid, as well as subretinal fibrosis. The new biochemical pathways implicated in this, with limited treatment options, especially for dry AMD, has created a fertile ground for novel therapeutics that we'll touch upon very shortly in this talk. So a quick kind of overview of prevalence. It is quite a prevalent disease. This data I've extrapolated from the UK population RCOF guidelines. And as you can see, it could be a public health issue in the elderly. This table I'll touch on very shortly. It takes you through different kind of aspects of AMD, like large drusen, pigmentary irregularity, retinal pigment epithelial detachments, and geographic atrophy, rates of prevalence and incidence. And you can see they can be quite variable. But what is drusen? Drusen is the building block of AMD. But what is it? So it's focal deposits of extracellular debris. It's located between basal lamina of RPE and the inner collagenous layer of Bruch's membrane. And it's found in normal aged humans or with pathological RMD. So drusen has 3 types: the soft drusen, cuticular, and subretinal drusenoid deposits, otherwise known as pseudodrusen or reticular drusen. And these pictures are very important. Try to make a mental note of them. This layer here on the top, in the top image, is the RPE, being the RPE. Let's just show you it. Where's the pointer? There, that's the RPE. That's also the RPE. So moving swiftly to soft drusen. So here is a color fundus photo of soft drusen, and we can see its yellow-white elevations. It could be anything from 63 microns to 1,000 microns, and it could show in a variable way in FFA and autofluorescence. The central portion of the drusen may appear slightly lighter than its edge. Infrared also can show some subtle variations in the grayscale tones. Green light, apparently in photos, which is available on anyone who has Heidelberg multi-color images, can provide some more contrast. Histologically, they're just low mounds that can be connected by basal linear deposits. And the RPE morphology and pigmentation can be minimally affected by this, especially in smaller soft drusen. So again, here, A is a color fundus photo, as you can see. B is the near infrared. And here is the autofluorescence. And most importantly, D is the OCT. So if you look at those 2 tiny arrows, they're going through these 2 small drusen and these 2 large ones. And you can see how it's presented here in the OCT scans. So again, the drusen color is not really related to the thickness of the sub-RPE material. can be the same color. However, it could be much thick in areas and other areas. And here on the autofluorescence, you could see there's a subtle increase in the hyper autofluorescence on the edges of the druse, as here is this one. Next one is cuticular drusen. So it's usually uniformly round and punctate, and it's usually densely packed to give this starry star arrangement. It's smaller in size than soft drusen. It can range from 50 to 75 microns. The OCT could show this image here, which is sawtooth appearance. And on FFA can show the starry sky appearance. So alone, if I show you one drusen on its own, you might not know it's cuticular. It could still be soft drusen. But when you see it as a part of the bigger picture, then you know it is cuticular drusen. Histologically, they're blunted triangles or prolate shapes. Usually the base is equal to the height. Again, this top bit here can jut into the RPE monolayer, and it can cause thinning of the RPE. This is another picture of cuticular drusen. This and this are the same, only this is 10 times magnified compared to this one. So again, note the small little drusen over there. It's more difficult to see in the infrared. And the autofluorescence image here shows the small hypo autofluorescent dots that may represent summation of both thinning of the underlying RPE and focal areas of RPE degeneration. So remember, the APCs can kind of cause RPE thinning. Another picture, this is the light microscope picture. This one is the electron microscope picture, and this is the FFA. So you can see here it's showing a starry sky appearance. Down here, you could see these, the thinning of the RPE over the apex and thickening at the base here, if you could look very carefully. And these small ovoid kind of accumulations. Then very important subject is subretinal drusenoid deposits. They're very important in knowing how to predict progression of the disease. So in size, they're similar to soft drusen. However, they can appear a bit whiter. They might be a little bit more punctate, closer to the macular area. And FFA can be variable. In near infrared, they can appear darker than the uninvolved surrounding area. Also in autofluorescence. In OCT, this is the most important bit, that it is sub-retinal, hence above the RPE. They can be interconnected, and their sizes, when they're interconnected, can be from 25 to 1,000 microns. And histologically, they vary in shape. They can be triangular, they can prolate, they can be conical, and they can be large enough to shorten the overlying photoreceptors, and it can disturb the external limiting membrane. These are examples. You could see here the pseudodrusen is overlying the RPE, and so is here. These are more photos of pseudodrusen that you could see with different imaging modalities, and you could see the variability between infrared, autofluorescence, and the most, I think, important imaging modality here is the OCT. So I really like this diagram. It shows you the difference between each type of drusen. So you can see the cuticular here causing thinning, the soft drusen being wide and not causing much disruption of the RPE above, and the subretinal drusenoid deposits being on top. and how they are. So remember that the RPE is where we see where the autofluorescence comes from and where the blue light is reflected. And the relationship to the RPE is what determines how we see this on fluorescein or autofluorescence images. So moving to more clinical things, I guess, is the risk factors affecting dry AMD and geographic atrophy progression. So we all need to be aware of the risk factors. So when you see a patient in your practice, you need to take some history. So as we all know, some risk factors are modifiable and some are unmodifiable. In this table, the ones in black are the well-established risk factors, and the ones in blue are still under kind of investigation or unclear risk factors. So systemic risk factors are cholesterol and lipid metabolism, cardiovascular disease, hyperthyroidism and oxidative stress, age, old age, we all know is the disease of old age, smoking, air pollution, BMI, and diet and micronutrients. Genetics, there's several genes that have been implicated in AMD progression. Finally, ocular risk factors, which are basically different types of drusen, different sizes of drusen, choroidal impairment. So how do we classify or stage macular degeneration? To start with, there's a Beckman classification, which is mainly used in epidemiological studies. Basically, it classifies eyes into normal, basically normal aging, which has no drusen exceeding 63 microns. Having 63 microns drusen is normal aging. Early AMD is basically drusen from 63 microns to 125 microns, and intermediate AMD is drusen over 125 microns with pigment changes. Late AMD could be neovascular, i.e. choroidal neovascular membrane of whichever type, or geographic atrophy. This is the epidemiological classification. How about the AREDS classification, or grading system, rather? So in the AREDS classification, there's a non-AMD eyes, which basically has fewer than 5 to 15 small-sized drusen with no pigmentary changes, or early AMD, which is several small-sized drusen or few medium-sized with no RPE anomalies. Stage 3, which is intermediate AMD, shows numerous medium-sized drusen and at least one large drusen with possible geographic atrophy, which is not involving the macula, and pigmentary changes and RPE anomalies. However, advanced or late AMD is geographic atrophy of the central macula or fovea. So the AREDS report number 8 came up with a simplified severity scale of age-related macular degeneration. Report number 18 can be found online. I think it's open access, I'm not quite sure. But if you wish to read further, you can go and refer to it. Basically what it does, it assigns one risk factor for the presence of one or more large drusen and one risk factor for the presence of any pigmentary anomaly. And then they basically add the risk factors between the two eyes, giving a scale from 0 to 4. To explain further, we'll go to the next slide. So right here, you can see that the approximate 5-year risk of developed advanced AMD in at least one eye increases. And you can remember this with this sequence. If there's 0 factors of the ones we've mentioned, it's 0.5%. That's progression in a 5-year. And if it's 1 factor, it's around 3% or 5%, 3 to 5%. 2 factors, it's around 12, 13%. 3 factors, around 25%. and 4 factors around 50%. So you can remember it through that sequence. For persons with no large drusen and only intermediate drusen in both eyes, this is counted as 1 risk factors. So here, that's like a nice example. So if a patient that you are seeing in clinic has got in the right eye large drusen, no, then they score 0. Yes, they score 1. So this is a 1. Then pigment changes. Yes, is another 1. So that's 2. And again, the same for the left eye. And then you calculate and you get your number 0 to 4. But we have to remember that progression kinetics can vary. So again, in AREDS study, the median follow-up of that study was 6 years. So the median time was 2.5 years for non-central to central GA progression. And for unilateral to bilateral GA progression, it was 7 years. The lesion growth has been estimated to be about 2 millimeters squared per year. So the simplified severity scale in report number 18 needed an update. So in this AREDS group, report number 42 has incorporated reticular pseudodrusen. That was published, I think, late 24, if I'm correct. And they came up with this very handy AMD calculator. The link is in the slide. However, not to get in and out of the slide, I'll put you a picture here. So basically, when you go online, it's free. Anyone can access it. You could put your patient's details, demographic details, retinal exam. Obviously, if you're in a big center and you know the gene, then that could be helpful. And then risk calculation. You don't have to fill everything, but obviously the more you fill, the more accurate your risk calculator would be. So there are some prognostic factors as lesion size, lesion site, focality, if it's focal or multifocal, the status of the fellow eye, low luminance vision, location of the lesion, if it's towards the periphery versus if it's towards the fovea, again on centrality, and I think it's a repeat freely, and then autofluorescence patterns and reticular pseudodrusen. It's quite an important risk factor, actually, and we'll see how later on. So lesion size and type. So the enlargement rate of lesion is very high if it's an intermediate lesion, lower if it's a larger lesion. However, the mean change in geographic atrophy area from baseline is higher in larger baseline lesions. So it's intuitive that if the baseline corrected visual acuity was worse with the larger baseline lesion, it's quite intuitive. This is a picture of all the risk factors we've discussed. So on average, in real life, how long would people believe it takes a patient to progress from non-central involving GA to central involving GA? So Retina Clinical Trend Survey has answered that question. And basically, most people thought that it's 2 to 3 years, just followed by 5 or more years. These are all retinal specialists. So we spoke about geographic atrophy, but we need to know how the OCT is helping us in this. So OCT helps us. Historically, geographic atrophy was a diagnosis made upon fundus photography or slit lamp examination. But now we can visualize different layers, and we can use en-face reconstruction to quantify borders of these layers. So we can potentially detect early stages of atrophy. So if you look here, this black area is absent RPE. So, and this area is sick RPE, the hyperfluorescent. Then when you go through this cross section on the OCT, there's lacking RPE here, and hence you can see the choroidal details because of the light penetration. So the classification of atrophy meeting came up with this classification system here, and it's based on the complete or incomplete atrophy of the RPE and or the outer retina. If it's homogeneous, then it's complete, and if it's non-homogeneous, it's incomplete retinal pigment epithelium and outer retinal atrophy. Or retinal pigment epithelium could be intact with some dysmorphic cells, however, with the outer retinal thinning, which again can be complete or incomplete. So what is in our toolbox for diagnosing AMD and GA? I'm not going to dwell a lot on this because I think most of the attendees would know that all of us nowadays do OCTs and OCTA. It's the mainstay of diagnosis. But obviously there are other imaging modalities, some for purely academic interest and some for pragmatic interests. So I'm not going to go through those tables as we've got a lot to cover. So basically this is pros and cons of every imaging modality that we might use. So this is a very important bit because we are very good at diagnosis when it comes to anatomical diagnosis. But what's the impact on the patient's vision? So a lot of the time, patients would come to clinic complaining sorely of poor vision. You look at the vision recorded in the notes and it says 6/9. So why are they complaining sorely? That's because you assess vision in more or less artificial environment. That's not the environment the patient deals with every day. So things that might be helpful is low luminance visual acuity, reading speed assessment, patient-related outcomes by creating questionnaires, and microperimetry. We'll go through some of these. So again, functional impairment is very important because visual acuity, as I've said, does not always capture progression. It's usually in the parafoveal macula, and patients can have severe reading difficulties because of the absolute scotomas. They can only read 3 letters at a time. So there's a real unmet need to find precise and sensitive functional endpoints to correlate with those anatomical findings, which will become even more valuable once we get treatments for geographic atrophy that we'll also touch upon very shortly. So again, going through the new and exciting things that we can do. One of them is AI. So AI has been recognized by the FDA in the section of geographic atrophy attenuation in some of the geographic atrophy trials as the RECLAIM phase 2. And these models can complete multimodal imaging with heat maps, highlighting focal progression points, and it can even predict progression speed. Again, it can be an indicator for patient selection for many of the treatments to come. Those AI models use machine learning to look through thousands upon thousands of OCT scans, and they come up with predictions. So microperimetry, as promised, unfortunately I don't have it in my hospital. It's one of the things that I wish to have. I believe once we get treatments for geographic atrophy, it will be standard practice to use microperimetry. It's much better for assessing visual function loss. There is point-wise sensitivity, and it can come up with local defects maps and interpolation maps as such. Finally, we're all in the age of mobile phones, and mobile apps are there to help patients assess their vision, their distortion, their contrast, and their telehealth apps are really on the rise. Home OCT, again, alongside telemedicine, it's quite widespread in the US, where they have a more kind of established home monitoring system. The patients can have that device at home. They measure, they assess themselves daily, and there's an observation center that collates all the data, and then the patient can see the physician if required. So this is what's new. But what do you have for now? So we've got some nice guidance for monitoring patients with dry AMD. And basically for early and intermediate AMD, our optometry colleagues and our optician colleagues should not be referring to secondary care, even when early AMD is confirmed. What the NICE guidelines advise us to do is routine sight test. OCT could be done for high-risk patients, usually annually, depending on the risk factors that we've discussed previously. And Amsler grids are essential for self-monitoring. Late AMD and geographic atrophy needs to be monitored with vision, OCT both eyes, and treat if neovascular AMD is found. So you can refer them to hospital eye services. And in anticipation for new geographic atrophy treatment, we need to identify those fast progression patients. And obviously consider low vision aids and sight support if required. If registry as sight impaired is required, also patients need to be counseled about that. So what's the prognosis in relation to Drusen? So why did I spend that much time talking about Drusen initially and not just jump into the exciting new treatments? Is because the type of Drusen can give us a little insight on how the patient will progress. For instance, soft drusen associated with type 1 neovascular membranes. Sub-retinal drusenoid deposits is associated with CRORA, historically known as geographic atrophy, which can cause worsening of visual outcomes. And also, it's associated with type 2 and type 3 neovascular membranes, which can also lead to worse visual outcomes. Again, these are little OCT phenotypes that could predict progression. So this is a focal hyperreflective material that can be associated with Drusen. These are plume tracks in the Henle fiber layer that can be associated with PED. And this is a hypertransmission defect. This is our Brooks membrane with no RPE, but then there is some basal laminar deposits that are still there. And this is some hyperreflective material here as well. Excuse me. So all these are kind of telltale signs in the OCT that we can look at and understand. So treatment, the mainstay of treatment until this point is addressing the modifiable risk factors. So the AREDS 2, that was the age-related eye disease study 2, that was preceded by the AREDS 1, looked at taking vitamins and minerals daily for AMD. Basically what they found that some nutritional supplements could help some people who have lots of drusen and lower the risk of wet AMD and vision loss in the second eye in people who lost vision in one eye from AMD. So usually if a patient lost one eye due to AMD, the GPs can prescribe this, I hope. The AREDS 1 formula contained beta-carotene, which is obviously carcinogenic to smokers. They took this out from the AREDS 2 and replaced it with lutein and zeaxanthin. in addition, obviously, to vitamin C, E, zinc, and copper. So, what about the new and upcoming treatments I've been nudging about the entirety of the talk? So, usually they aim to slow or prevent disease progression. And the only functional endpoint here is vision, which is insufficient, and hence the need for these other visual endpoints that I've discussed. Anatomical changes can precede vision loss if we're talking about best-corrected vision. So we need to find ways to examine those patients better than the just best-corrected visual acuity. So now going on to the agents. I know you're all very keen to know what they are. So it's the complement treatment. So there's two types of complement, C3 and C5 complement. They are injectable, can be monthly or bi-monthly. Lots of studies are taking place as we speak. Oaks and Derby are in phase 3 now. Gather 2 is in phase 3, and they're all looking at different at complements versus sham injections, and also monthly versus bi-monthly injections, and what's the best outcomes for the patients. So how do we select patients for this treatment? So based on trial data, early treatment is advocated. Non-foveal involving GA, however, once it's out there, we can also offer to others. We usually treat the better eye to prevent foveal involvement, which I find it a hard sell for the patient who lost one eye due to geographic atrophy. Tell them we're not going to inject the bad eye, actually we're going to inject your better eye. So I think when we go through the risk and benefits, it's going to be very interesting conversations. And we could do it monthly or bi-monthly, depending on the agent. And there's lots of studies going on about that at the moment. And set up expectations that it is stabilization, not really improvement. And rather than stabilization, it's progression in a slower rate, to be more accurate. Another challenge that I'm anticipating is when to stop injecting. So we have very specific visual and anatomical endpoints to stop injecting wet AMD. But how about dry? And hence the need for things like microperimetry that might increase once we've got these treatments available. The second thing is when to offer the treatment. So what's the optimal timing for the treatment, depending on the risk prediction? So lots of ongoing research about this. So there's lots of questions that are still unanswered. So another treatment strategy is photobiomodulation. This is not available in the NHS. However, some private providers have it. It is FDA approved, not NICE approved yet. And I think the problem with the studies is that the statistically significant improvements do not really translate into clinical benefits enough for it to be NICE approved. So they need a larger sample size for photobiomodulation, I think, to be widely practiced by the NHS. So a little reminder of our AMD classification, where it says advanced here could be neovascular membrane or geographic atrophy. Just to lead on to our next slide, which is neovascular AMD. So as we have established, it's stage 4 or late advanced AMD. The Conan study group, which is consensus on nomenclature of AMD study group, has a classified neovascularization as followed. Type 1, which is sub-RPE, previously known as occult. Type 2, which is sub-retinal. And type 3, which is retinal. So imaging, as we have all kind of experienced in our own practices, OCT, then OCT, then OCT some more. OCTA is on the rise. In our hospital, it's almost completely replaced FFA. We would only resort to FFA if we're unsure. ICGA would only, again, use if we're suspecting polyps. At the end of the day, this doesn't affect the treatment as much as long as the patient is responding well to their anti-VEGF treatments. Monitoring, we've got the visual loss, more than 5 ETDRS letters, OCT scans, hemorrhage, and FFA and ICGA that I've said are hardly used for monitoring nor diagnosis nowadays. So some OCT findings that we might find in wet or neovascular AMD, intraretinal fluid cysts, subretinal fluid. So this is the intraretinal cyst. This is subretinal fluid, sub-RPE fibrovascular PED, multi-layered PED. We could see that in, you can just about see a little bit there, in chronic type 1 with a lot of injections. So if you see patients who had many injections and if they've got chronic type 1, you might see this bilayered PED. And then finally, it's outer-retinal tubulation. So these are basically dead photoreceptor cells in a circular pattern. So this is not intraretinal fluid. It's just a sign of chronicity. So don't please don't inject these patients. So again, more novel signs, if you will, like SHRM, which is subretinal hyperreflective material. And this can represent fibrin, hemorrhage, or neovascular tissue, or fibrotic even tissue. And it's associated with worse visual outcomes and higher incidence of scarring. And then there's intraretinal hyperreflective foci, which is a risk factor for neovascular AMD and geographic atrophy. So again, a little reminder of these little biomarkers that you could see in your OCTs. Once again, some novel things. So AI and machine learning. There's lots of publications about AI and machine learning. It's all the rage nowadays. Home OCT, as I've mentioned before, it has been cleared by the FDA and it's AI enabled. It's called Scanly, I believe. And it can provide lots of data about the disease dynamic as the patients are doing this every day in their home. I think we're ready for a poll because I think I might have missed the first poll. If you could do it, please, just to make sure people are awake. Madeline?
So we've got the first poll on the screen right now. If everybody could please register, how would you describe this stage of AMD with the image that's provided? Just to make sure everybody participates in all 3 of our polling questions. We've got 2 left just to ensure everybody gets their interactive CPD point. We'll give it about 30 more seconds just to make sure that everybody participates, and then we will continue with the presentation. Perfect. So for the poll 1, 14% they would describe this as early, 73 said intermediate, and 12% said late or advanced.
Fabulous. That's what I'd like to hear. So well done, everybody. So evolving concepts. Now, more recently, we're thinking about the choroidal neovascular membrane as a protective response to improve oxygenation and nutrient supply, especially if it's not associated with leakage. So non-exudative macular neovascularization, if you say it on OCT, you might not want to treat it and just follow it up. If the vision is good and patient even have a little subretinal fluid, again, there is tolerance to some amount of subretinal fluid. Treatment. Before the treatment, I'd like to do the next question, please, on the poll, because I think I missed the first one.
All right, so poll 2 is multiple choice, so please select all that apply. Modifiable risk factors that can be addressed in dry AMD include, please tick all that apply. We'll give you about 35 to 40 seconds to answer this. Alrighty, it looks like everybody's just finishing up. Everybody, if you could get your last votes in, and then I'll read out the results for you. So we have overall, everybody said that they think smoking is the most common modifiable risk factor, with air pollution and oxidative stress in second place and age in third.
Excellent. Okay, that's really good. But age we can't really modify because can't really help people getting old. But yes, thank you, everybody. So we'll go now to the more familiar subject of neovascular AMD treatment. So all these are anti-VEGF. I would like to bring your attention to the last two, which are claimed to be the more longer acting, that you can extend treatment to 12 weeks with either one. However, one I haven't mentioned, which is the brolucizumab, that went out of favor because of the vasculitic adverse events. So we had it for a short while in our hospital, but then decided not to use it because of that reason. I'm not sure about your practices and hospitals. You might still be using it, but where I am, which is the Midlands, most hospitals have kind of not continued using it. So this is a slide taken out of one of the clinical trial results. Basically, it's about different anti-VEGF. So you need to know that some of them is single target for VEGF-A as the ranibizumab and the brolucizumab. And some of them are dual targets against VEGF-A and Ang-2, like the faricimab, and then the multi-target as aflibercept. So basically, the idea of aflibercept being 8 milligrams is to increasing the molar dose of anti-VEGF can potentially increase benefits of longevity. So here there are two durable agents, which is the faricimab and aflibercept, all have very good results in their clinical trials. However, there's no head-to-head trials between the two, and there's no real-life experience that's been published yet for the aflibercept 8 milligrams. So we're still awaiting those results. However, the far-wide trial results are out, which is looking at the faricimab in NHS hospitals. So this is real-life clinical trials results that are very promising. So it's really real-life experience from different trusts across the country. And to be fair, I've had a look at the results and they're quite promising. And it's all about reducing the injection burden on the patient. So we talked about prognosis depending on Drusen type. Now we need to talk about prognosis depending on the neovascular membrane type. So with the Harvard trial data, it told us that type 1 macular neovascularization has got the best vision outcome, independent of the subretinal fluid. And subretinal type 2 and the mixed type is the worst visual outcome, especially if intraretinal fluid is present. Now we have other biomarkers like the SHRM and the intraretinal hyperreflective material that could also tell us that it will be worse outcomes. Then the response to anti-VEGF in terms of vision gain shows that the type 3 is most responsive in terms of vision gain, and baseline, the neovascularization type can predict treatment response in clinical practice. So when you have this knowledge, you can actually, when the patient asks you how many injections do you anticipate, if you know this, you could actually tell them, well, your type of neovascular membrane tends to require more injections or less injections, etc. Now back to the new and exciting. So we talked about long-acting drugs. Now we need to talk about long-acting gadgets. So most of you will remember back in 2021, there was a lot of excitement about the port delivery system that gets refilled with ranibizumab every 6 months. Basically, it's an implant, usually, has to be inserted by a vitreoretinal surgeon at the pars plana, and then covered with a conjunctiva, and you get refillable injections basically every 6 months as an outpatient procedure. Initially, it caused lots of complication, hence it fell out of favor, and then now it's reintroduced again. A very similar system could be used with a bispecific antibody, which is angiopoietin 2 inhibitor, along with VEGF receptor antagonist, which is called zifibancimig. And again, this is still under clinical trials. Another way that we could do is intravitreal drug delivery implants like the axitinib and the vorolanib. They're in phase 3 and 2 trials at the moment, respectively. They have 6 to 9 months durability and broad angiogenic properties, and they are bioerodible, meaning they dissolve. The suprachoroidal drug delivery, so there's a lot of excitement about suprachoroidal space utilization, as it maintains high drug concentration in the retina and RPE choroid and sclera, however, minimal drug levels in vitreous and anterior chamber. It's mainly used for gene therapy, along with the subretinal drug delivery, which is done by pars plana vitrectomy, and the drug is basically injected subretinally as they would do, for instance, with TPA. Again, those two will require a vitreoretinal surgeon to perform the procedure. But it's mainly used for gene therapy, which is still under clinical trial. And to give you a taste of that, we've got these 3 gene therapy trials at different phases, and each one of them, so the PRISM and LUNA trial for those respective agents are intravitreal drugs. However, the AVIATE is subretinal, and Atmosphere and Ascent are suprachoroidal medications. One final thought is about radiotactic, a stereotactic radiotherapy. Basically, it's very similar to a small dose of X-ray. It's focused radiation delivered directly to the affected area of the retina, and potentially it reduces the need for frequent anti-VEGF injections while preserving the vision. This is again under a lot of research, and I believe the next 5 to 10 years should be very exciting for retinal specialists. We'll need the final question on the poll, please. Madeline?
So I've just launched poll number 3. Which of the following is a dual target anti-VEGF? And this is single choice. There's one right answer. While we wait for those answers to come in, I want to give a special thank you to Dr. Yasmine for that very informative session. We had a lot of great Q&A questions come in from everybody. I would encourage other delegates right now, if you have any questions at the moment for Dr. Yasmine about the session or about anything else to do with AMD, please pop them in the Q&A bit right now, and we will do a short Q&A with Dr. Yasmine. All right. I've just ended the 3rd poll. It looks like the answers are very tight. Dr. Yasmine, if you want to reveal the correct answer for this one, and we can see how everyone fared.
So it's just the faricimab. So the 42% were right.
Awesome. Good job, everybody. Perfect. Well, thank you again, Dr. Yasmine. I'm going to offer our sponsors to join back on camera with us while we do a short Q&A session with all of our questions that we've got pouring in from our delegates. So I will start off with a question. Should we be referring all patients with any level of retinal or subfluid to secondary care, or should we be monitoring cases with very little fluid? What would you say?
Depends on where the fluid is. So most people, well, the treatment criteria is from 25 to, so it depends on the vision of the patient. So if they've got 6/6 vision, that's good. But by the time you're fair, it might be different. So I would refer anyone with a significant amount of subretinal fluid, and you can see that the other eye, but then you have to be wary of the other condition causing subretinal fluid, like central serous retinopathy, for instance. So if you're confident that this patient has AMD and they've got subretinal fluid and the vision is anything from 75 to 25 ETDRS letter, then they're within the treatment criteria. Always when in doubt, I would refer to hospital. There's a lot of telemedicine now between consultants. There's things like, in my hospital, there's something called Consultant Connect, where you send the images, they're reviewed by a consultant, and they can give you direct advice. In other, we have like rapid access clinics where you could just refer a patient for an OCT, and then a consultant makes a decision whether they stay in hospital or go back to the optometrist. So our colleagues should not feel pressure to make big decisions if they feel they're not equipped to do it. And again, there's tons of biomarkers. So if in doubt, refer. No one will blame you for referring. But if vision's really good and it's not been changing for a while, you can possibly just follow up.
Sounds good. We've got another question. What is the best treatment if one eye is already lost to wet AMD with 6/48 and the other eye is recently diagnosed with wet AMD 6/7.5?
I think I can't answer this question because you need to look at the OCT scans and the type of neovascularization, and also the amount of time it took for the first eye to be lost, and has it been lost due to wet AMD or has it been lost due to geographic atrophy? So VEGF agents, they depends on obviously the hospital and the protocols. So some people advocate using a dual agent or a multiple agent to reduce the treatment load and the number of injections given to the patient. Again, we need to think about not only the treatment burden on the patient, that again, although very, very low, there is risk of endophthalmitis. So sometimes I would, in my practice, I'd prefer a longer acting agent so that I'm not injecting the patient more frequently, if possible. And again, it all depends, it all boils down to the OCT biomarkers in that specific patient.
Makes sense. How long should we treat with injections if fluid has resolved and vision is 6/9 in the case of neovascular AMD?
Well, depends on your local protocol. So in our hospital, we mainly put patients on treat and extend. We extend 3 times at the end, and if they are not getting any more fluid and the vision is stable, i.e. within 5 ETDRS letters, we tend to stop and keep on either a virtual clinic where they get OCTs or with a nurse-led clinic. And if they don't get any recurrences within a year, we can discharge to the community with advice, because otherwise we'll never discharge any of our patients.
Makes sense. We've got a question from Jeremiah Kelly. They would like to know, is there a role for ERG or dark adaptation in functional analysis of patient vision?
It's actually a very good question. I haven't thought about that, but it is a very long and tedious test to put the patient through. For while there are things like microperimetry where they can be done in your department. So basically in the department I work in, electrophysiology is done in a completely different department and requires relatively an exhaustive setup. While things like microperimetry is just like visual fields, you could just have them locally done by a technician. They're quick and easy. So theoretically, perhaps, but practically, I don't think so. I think it's a lot of work for small purchase, if that makes sense.
That makes sense. I think we have time for 2 more questions. If anybody else has any other questions, I'd recommend that you pop them in the chat right now. We have got a question from James. Are you still looking for patients with parafoveal GA to take part in your trials?
No, because I am not. The reason is my hospital is not involved in the trials as. So me personally, no. They haven't. They finished recruitment for the phase 3 trial for both the GA complement drugs. At this point, we're awaiting the results.
That makes sense. And then Wasim would like to know, what are the best supplements that you would recommend for AMD?
Any AREDS 2 supplement. So as long as they contain all the nutrients that I've mentioned, they should be okay. As long as they have so anything that says AREDS 2 formula, that's all they need.